All right, Section 2, Chapter 7. So in Section 1, or what we did as the second section during this course, the first section, of course, being the skills, the second section being preparatory, but the first section of the textbook was cover kind of the confines, the operational confines that we use in EMS. Talked about lots of things such as medical terminology, legal aspects of it, consent, and so on and so forth. In this chapter, we now start turning the corner, and some of this may be fairly new to you guys. Section 2, where we now start to talk about really the human body, how it functions, the medication, pathophysiology, lifespan development, many of those things are going to potentially be new materials to you guys. So this is a tough section. I will remind you, particularly for this section, but as with all sections, that simply listening to the lecture is not sufficient. You need to read your textbooks, study, and take notes. With Chapter 7, you are going to have to do a lot of really kind of self-study and look for ways to pick these things up. These aren't really, there's not a lot of concepts in this chapter. There's a lot of very specific memorization things that need to be done during this chapter. So there's not a one easy way to do this. Some of my recommendations include looking at words, picking out the parts of the words that you know, and the parts of the words that you don't know, try to think back through your mind of things that it may sound like, and it may be able to help you come up with some of these things. So again, a lot of memorization here. We'll talk about the concepts for the first couple of slides, and then we really kind of get into the words themselves. All right, so the education standard here is the AEMT uses foundational anatomical and medical terms and abbreviations in written and oral communications with colleagues and other healthcare professionals. So we're speaking the speak. The objectives, of course, there's really not a ton of objectives for this chapter, but there is a lot of terminology here. We have 5 objectives that you'll find on page 134 in your text. So every profession has its unique language. I brought this up before. It allows us to precisely and efficiently transmit a meaning among individuals who are fluent in that language. So again, we not only speak the medical language, but we have the dialect of the medical language that particularly pertains to EMS, because nurses don't spend much time, if any, during nursing school learning about long spine boards. Nobody else uses palpation blood pressures. Nobody else uses KEDs or mask pants. So it's really us. So it's important that we recognize that, so when we're speaking outside our circle, that we can make sure people are in the loop. So medical terminology used by all healthcare professionals is a set of common prefixes, root words, and suffixes. Additionally, we have a number of symbols and abbreviations and conventions for writing numbers in healthcare. Sometimes we use these terms because it's quicker to use a single medical term. In fact, sometimes it can greatly shorten up what we have to say by using a medical term. And additionally, sometimes it is important for us to more or less talk in code in order to keep people from immediately freaking out about what we're talking about. So that think about it goes back to your Chapter 7 case study. So what are some possible disadvantages to using medical terms? Well, sometimes people think they know what they mean and they don't. I brought up, I know at the last skills day in Council Bluffs, I brought up the fact that one time I heard a squad bringing a patient in, and they had said that their patient had a possible fractured cervix and that they had applied a cervical collar. Well, nice try. However, the cervix is a part of the internal female reproductive anatomy, and if we had tried to put a C-collar on that, I'm guessing that that patient would have been less than receptive to that. So trying to use a medical term and not actually using it correctly or not knowing at all what it means can be a disadvantage. And then if you can't remember, just say it. Okay, just write it out or just say it if you can't remember the right term. It's better to use the plain English than it is to use an incorrect term. So as we start to talk medical terminology basics, most of our terms have some sort of a root word. So the root word usually has the major meaning, the major concept that we're going for behind it. So it is going to draw our attention to usually a specific part, disease, issue, or problem. Now, in addition to a root word, well, here, a few root words, adeno, carcin, cardi, site, derm, derma, dermato, entero, gaster, gyne, hema, hydra, necra, somat, path. Okay, so we can start to see that these are really guiding us to a specific concept. So whether we're talking glands or cancers or hearts or whatever, it really guides us into that area. So we can also note that there's a combining form with some of these root words. Actually, all of them have an example behind them. It's typically an O or an A that helps us to combine it with any other terms that we're going to use. So carcin or carcino, carcinogenic, means to cause cancer. Sometimes we also have a prefix, and a prefix is placed at the beginning of a root word to modify its meaning. So we may be talking about a very specific area, a very specific part, and so that prefix helps us to gain that information. So a couple of things here: nulli, hemi, semi, uni, mono, bi, poly, multi, tri, tetra, quad. These usually have to do with numerics, numeric or quantitative prefixes. So something like semi or hemi would be half. So half of the body, hemiplegia. You're talking about, well, they have polycythemia there, which is too many blood vessels. So these are the fairly common ones and the fairly easy ones. When we start to put these together, these prefixes, then we can start tacking them on with some of the other root words, and it really starts to build a word for us. Some other common prefixes, a or an, both mean without. Anti is in front of. Anti is against. Brady is slow. Con is together or with. Dis, painful or difficult. I don't need to read these to you, as well as all these charts are in your textbook as well. So a lot of these prefixes help better qualify or quantify what exactly we're talking about. Macro, micro, pseudo, retro, sub, super, supra. Then we may also have a suffix that gets attached, and that suffix is placed at the end of the word, and it modifies that word even further. So some examples might be, they got tons of them listed here: algia, pain, site, cell, ectomy, removal, gram, a picture of, graph, an instrument for recording, graphy, the process of recording, ostomy, which is a surgical opening, oma has to do with tumors, otomy, cutting into, pathy, disease. And they have lots of examples listed there. So rhino, meaning nose, rhino being the root word, plasty being the suffix, meaning what are we going to do with it. So what are we going to do with the nose? We're going to repair it surgically. So that's a rhinoplasty. We may have that combining vowel or combining form, as they sometimes also call it. It connects the root word to a suffix, or it may combine two different root words. Spelling and pronunciation are very important. You need to have a firm grip on these, and because one letter, changing one letter, can really change the meaning of what you're discussing. So spelling is important, and if we're doing written work in the classroom, spelling will be taken into consideration. So, rules for pluralizing medical terms are based off the letter in which that term ends with. So to pluralize some of the words, we may add a, ax, n, ma, on. These are a little less commonly used, but there's a few additional endings that we may see there that just slightly alter it. Avoiding jargon and slang. To avoid jargon and slang, particularly if we're outside of our circle, outside of our little team, it can be difficult to actually understand what you're discussing. To take another look at 10 codes, using radio 10 codes. That's kind of a jargon or a slang. It's something that we use maybe in one area, but other areas may not understand it. Additionally, using jargon or slang or terminology a lot of times with a patient, they really don't understand what you're talking about. So if you ask them if they ever had any issues with their endocrine system, they may say no, even though they're on insulin and they clearly take insulin every day for their diabetes. Well, diabetes is a problem of the endocrine system. They don't understand that. We talked about kind of the potential consequences for misspelling or mispronouncing medical terms. So we'll break then into the anatomical terms. We use anatomical terms to help us pinpoint specific areas of the body. You can find these pictures, of course, in your textbook. This one is on 140. So the various positions and directions. Now, understanding that sometimes these terms are relative. So, and an example of that, let's take the elbow. You can look at on that woman's arm, it says distal pointing towards the hand, proximal pointing towards the shoulder. The elbow can be either proximal or distal. It all depends on perspective. So if we're talking about the wrist in comparison to the elbow, the wrist is distal to the elbow. But if we're talking about the shoulder compared to the elbow, then it is more proximal. The shoulder is proximal from the elbow. So you have to remember that there's a perspective. There has to be a reference point. So to use it simply by itself many times, you lose some of that meaning. So the midline, that really shouldn't be anything out of the ordinary. Midline is splits the body down the middle in halves. Anything that's towards the midline from another point is considered medial. Anything that's away from the midline is considered lateral. So we know that if we're going to drive down an interstate, we have a median right down the middle. And in football, if you're going to throw the ball to somebody else that's off at least to your side, not out in front of you, they're off to your side, you can lateral it to them or throw it to the side. We also have palmar and plantar. Palmar and plantar have to do with the surfaces of the hands and feet respectively. So palmar, the palm side of the hand, plantar, or the downside of the foot where you walk on. Remember that it's a patient's right and a patient's left, so we don't use our right and left. It's the patient's right and left. Distal and proximal. Distal is more further away. Proximal is in closer proximity, so distal further away, proximal closer. Now we also may have posterior and anterior. The anterior, posterior, I always remember it as the A comes before the P, because if you're walking forward, your front comes before your back. So A, or you might sit back and lean up on a post with your posterior. So some other terms that get used occasionally, and it's probably more in animal sciences than it is in human medicine, is the terms ventral and dorsal. Things that do not walk erect, they tend to use ventral and dorsal more commonly. Ventral meaning the underside or the belly side, dorsal meaning the backside. I always remember this because the big fin on the back of a shark is the dorsal fin. So that's how I remember it. We have superior and inferior. Superior meaning towards the head, inferior towards the foot. We can also divide the patient's body into by the mid-axillary point, or the mid-axillary plane, where it goes and basically divides the patient in front and back halves through the center of the armpit. With that being said, we also have some planes, and that last term that we used there, so when we said mid-axillary, the mid-axillary plane, if we would cut the body in half front and back, is the frontal or the coronal plane that cuts the body in the front and back half. We have sagittal planes, and sagittal planes divide the body into right and left sections. We may have the mid-sagittal plane. The mid-sagittal plane is perfectly down the middle, so right down the midline. It cuts the body in almost perfect right and left halves. And then we may also have a transverse plane, or the horizontal plane, that cuts you into tops and bottoms. So if we go back and take the body and cut it into a sagittal plane, a medial plane, if you will, we can look at the cavities that we see and discuss in the body. Now, these are majority of the major cavities. There are a couple of other minor cavities that get referred to from time to time. We have the cranial cavity and the spinal cavity. Those combined make up the area that holds your central nervous system. Cranium is your skull, what is inside the skull, or where the brain is, and the spinal cavity is the area down through the spinal column that the spinal cord sits. We may also have discussions about the thoracic cavity, and the thoracic cavity is everything that is above the diaphragm. The diaphragm is the dividing point within the chest. So basically inside the ribs, behind the sternum, in front of the spinal column, and above the diaphragm, below the shoulder, basically below the collarbones, is the thoracic cavity. So the heart, the lungs, greater vessels. We have the abdominal cavity, and the abdominal cavity is everything south of the diaphragm till where you get down to the pelvic bowl. So kind of where the pelvis is the dividing point there. And so the abdominal cavity contains most of your digestive organs. You have the pelvic cavity, which is everything down in the pelvic bowl, where this houses usually your rectum, your urinary bladder, and female reproductive organs. And then in some cases, they will actually refer to that as the abdominopelvic cavity, for the simple fact that there isn't a natural dividing point in there that divides the two cavities. So terms of position and direction are useful in describing the location of body structures and abnormal findings. So you maybe have a patient who has a laceration on their lower leg. Well, the easiest way to say that would be on the distal leg, the right distal leg. Maybe you want to say on the medial surface of the distal right leg. Now, technically, the leg has to do with the lower leg. All right, and then anatomic position and body planes get obviously used for points of reference. So here's a few additional positional and directional terms to go along with what we have touched on from the pictures. These would include abduction and adduction. These are the opposite of each other. When you have, let's say your child is taken away from you, they are abducted. So to abduct something is to move it away or to take it away. Adduct it, you move it in, you add it to yourself, is to move it towards the midline. So if you're standing with your arms down at your side and you raise them up so they're outward in a T shape, then you have abducted them. But when you pull them back down to your sides again, you have adducted them. Anterior and posterior, discuss those toward and front, or toward the front, toward the back. Apex is the tip of a structure. Now this is not always common sense. The apex of the heart is pointed downwards towards basically your stomach on your lower left chest area. The apex of the lungs, however, is up under your collarbones. So that's where the pointy part is, or the tip part. So you may have an apex to your liver. So they're not always down. Sometimes they're up, lying in weird positions. And the base is typically the lower part of the structure. So the base of the lungs rest on the diaphragm. Caudal is towards the tail or towards the feet in erect walking animals, so humans. So caudal is towards the feet. Cephalid is towards the head. We talk about hydrocephalus or hydrocephalus. That means water on the brain, water on the head. Deep, obviously, would be inside. Superficial would be towards the outside. Distal, further away from the point of reference. Dorsal, the back. Extension is to straighten a joint, to move the two parts further apart. So to extend your arm, you take the bend out of your elbow and put it out straight. Extension sometimes isn't that easy. So we have hyperextension. When we extend the neck, we actually tip the head backwards. When we flex the neck, we bring the chin towards the chest. So flexion is the bending, so like bending the elbow. We may also have inferior, which is towards the feet. Lateral, medial, covered those. Midline, we've covered that. Posterior, got that one. Prone is lying face down. Proximal, near the midpoint. Superficial is towards the outer surface, so in opposition to deep. Superior, we've talked about. Supine is lying flat on their back. And we've talked about ventral. So, patient positioning. There are a number of positions that we put a patient into, and we will use those terms from time to time, particularly in patient care reports, to further describe kind of what we've done with our patients, or in what position we may have found them, or what position we may have decided to move them to. All right, so we have prone. Prone is lying flat on your abdomen, basically face down. Left lateral and right lateral recumbent. That's to lay on your side with the appropriate side that you are laying on identified. So if you're laying on your left side, it's left lateral. Laying on your right side, it's right lateral. Supine is lying flat, face up. We have Fowlers and we have semi-Fowlers. Fowlers is generally used to refer to sitting positions. In some places they may refer to it as patients that are sitting at least 45-degree angle. There are others that debate that. Semi-Fowlers is usually referred to as roughly 15 to 20 up to 45 degrees or so. but you can also use sitting, of course, or semi-sitting. So each body part is going to have tons of terms associated with it. We're not going to spend a lot of time in this chapter specifically looking at those terms because as we come to them as part of our studies of the various chapters, that is something that we will touch on at those times. So note that there's going to be lots and lots and lots of different potential terms. You can see numerous terms in your textbook on really the charts of 714. They're covering a lot of terms in there. And then symbols and abbreviations. We obviously use a lot of symbols and abbreviations to shorten things up for us a bit. You can look at tons and tons of those as well in the charts in the textbook there. Use them. If you're not completely familiar with them, then don't use them. A lot of times we also have abbreviations that either are not standard or we may have abbreviations that are very similar to each other. So we'll take, for example, CA. If we use the abbreviation CA typically in medical terms refers to cancer. However, C, capital C, little a, and then you add a couple of plus signs behind it actually means the chemical symbol for calcium. So there are things that can be easily confused. So know what the potential different ones are. I mean, if you look even at the one here on the screen, PE can be physical exam, can be pulmonary embolism. So there are lots of times in which there may be some confusion in what you're exactly dealing with. Standard medical charting abbreviations. Honestly, those ethnic ones really don't get used often. The AA, the A, the B, those really don't get used much. But chief complaint, complains of, CHS I've never seen used. Date of birth, DOB, that's fairly common. Differential diagnoses, not something that would be a common concept to most of you guys at this point, but eventually we'll get there where we're talking differential diagnoses. EDC, estimated date of confinement or your due date. Family history, there's the symbol for female. History, abdominal pain. Most of the time that one gets ABD pain. And so on and so forth. I don't need to continue to read these off. Symbol for male. Large variety of diagnoses ones. All right, so the think about it we have here. The patient's AA and O times 3. Skin's warm, moist, normal in color. Vital signs, blood pressure 118/72, pulse of 84 and regular. RR, respiratory rate is 16. The PE is superficial lacerations and abrasions to the palmar surfaces of the hand bilaterally. Deformities to the anterior left leg, 3 inches proximal to the ankle, with edema and discoloration. Distal pulse, motor, and sensory function is intact. Can you figure out what they're trying to say here? I think in many cases people can kind of work their way around and say, oh yeah, I get that, I see what they're going for. But if there's anything on here that's not familiar to you, that's definitely a key to go look that up, see where we can come up with that. You should be able to interpret this for somebody else. Like I mentioned, there's a lot of content in this chapter, and there's not a nice, easy way to just give it to you. So a lot of this is going to require you to study some of these terms. Now, the beauty of it is if you bookmark this, you can refer to this as we go along through the rest of the course, and you can kind of start to pick these things up. So unique languages identify our particular profession. With proper use of medical terminology, symbols, and abbreviations is required of all healthcare providers. And I guess one more word maybe should be made for abbreviations and symbols is only used ones that are approved by your agency. Many agencies, hospitals, have an approved abbreviations list because there's people that will do all kinds of different abbreviations. They think it sounds right, so they start using it. Well, if you would ever be called to court on it and have to defend it, they may ask you, is this an approved abbreviation within your facility? No? Okay. It goes to discredit you. Medical terms identify like common root words, prefixes, and suffixes. The use of proper term, proper spelling, and accepted symbols and abbreviations is critical. In doubt, use a medical dictionary to confirm meanings. And if you cannot find clarification, use plain text to express your ideas. So, with that being said, medical dictionary. If you do not have a medical dictionary, it's probably a good time to consider getting one. Medical dictionaries, I still have the one that I got many, many moons ago when I went to paramedic school. Yes, it's a bit dated, but you can pick these up in most bookstores or there's tons of online resources. Again, you need to be cautious with the online resources because, Wikipedia, anybody can post anything on.